Hello everyone, today we're going to talk about the prevention of DVT and PE in surgical patients. First off, venous thromboembolic disease is a disease state that is caused by clot formation and mobilization within a vein, i.e. when a blood clot breaks loose and travels through the blood. VTE presents clinically as deep venous thrombosis, DVT, and pulmonary embolism, PE. Venous thromboembolism, VTE, is a major health and financial burden that affects the community. This condition is the third most common vascular disorder in Caucasian populations after myocardial infarction and stroke. About half the people with DVT don't have symptoms. Any symptoms that do occur will be in the affected leg or the area where the clot is found. Signs and symptoms can include swelling, pain, redness, leg cramps, and discoloration of the skin. If the clot moves into the lungs and you develop PE, you may have symptoms such as chest pain, shortness of breath, coughing, tachycardia, tachypnea. Leg edema is a common problem in older patients, with a wide range of possible causes. The diagnosis can be narrowed down by categorizing the edema according to its duration, acute or chronic, distribution, unilateral or bilateral, and accompanying symptoms such as dyspnea, pain, thickening of the skin, and pigmentation. The differential diagnosis includes systemic illnesses such as heart failure, liver disease, malnutrition, and thyroid disorder, local conditions such as pelvic tumors, infection, trauma, and venous thrombosis, and various medications known to increase the risk of edema of the lower extremities. Key elements of the history include: what is the duration of the edema? Acute, less than 72 hours, versus chronic. If the onset is acute, deep vein thrombosis should be strongly considered. The 72-hour cutoff is commonly cited but arbitrary. Is the edema painful? Deep vein thrombosis and reflex sympathetic dystrophy are usually painful. Chronic venous insufficiency can cause low-grade aching. Lymphedema is usually painless. What drugs are being taken? Calcium channel blockers, prednisone, and anti-inflammatory drugs are common causes of leg edema. Is there a history of systemic disease, heart, liver, or kidney disease? Is there a history of pelvic or abdominal neoplasm or radiation? Does the edema improve overnight? Venous edema is more likely than lymphedema to improve overnight. Is there a history consistent with sleep apnea? Sleep apnea can cause pulmonary hypertension, which is a common cause of leg edema. Findings that may increase the suspicion of sleep apnea include loud snoring or apnea noted by the sleep partner, daytime somnolence, or a neck circumference greater than 17 inches. Thank you.
السلام عليكم، معكم زميلكم نور الدين مهند الجبوري. راح أحكي عن الجزء الثاني من سيمينار ال DVT prevention and DVT prevention in surgical patients. الجزء الأول كان مع زميل تيراندو، كان بيحكي عن ال definition and history taking. بهذا الجزء راح أحكي عن physical examination and pathophysiology. I will start by physical examination of the lower limb. As any other examination, we should have a proper exposure. The proper exposure of the lower limb is the whole lower limbs bilaterally from the toes till the mid-thigh. Then we should have a general observation of the patient. We look if the patient looks well, conscious, oriented or not, breathing comfortably. We see if he has a shortness of breath or chest pain. That may indicate pulmonary embolism after DVT. If there is any pain, pale, jaundice or cyanosis, and if there is any IV lines or dressings or masks. Then we should measure the vital signs. It's important in patients with cellulitis, as those patients may have septicemia, and in patients with DVT, as those patients may have pulmonary embolism as a complication. So we should measure the temperature, blood pressure, pulse rate, and the respiratory rate. Inspection. We should inspect both legs and compare them. We see if there is any ulcers, redness, any apparent swelling across the legs, any dilated veins that lead to venous stasis, which is a risk factor for DVT, and any way or route of entry of cellulitis. So we should examine between the toes for fungal infection. Then we look for the changes in the skin color, such as turning pale, red, blue, or any other pigmentation, and we see if there are any lesions, masses, amputation, any nails abnormality, and we inspect the dorsum of the legs and between the toes. Then we move to the palpation. First, we use the dorsum of our hands to feel the temperature of the legs bilaterally, and at the same time we start from the toes and move upward till the knee, and we compare the temperature between the both legs of the patient. Then we ask the patient if he has a pain in his legs. Then we palpate each leg for any tenderness. The tenderness is present in approximately 75% of the patient with DVT, and it's usually in the calf muscles. Then we assess if there is any edema, and if yes, is pitting or not. We check the pulses, dorsalis pedis, tibial, posterior tibialis, and popliteal. We check the capillary fill. It should be less than 2 seconds, as we know. Hoffman sign. The leg extended at the knee joint, and we make forceful dorsiflexion of the foot at the ankle. This may indicate a pain in the calf, which may indicate DVT. But actually it's not used anymore because it has low specificity and may increase the risk of showering embolism. This means a thrombus to be dislodged and goes through venous circulation, through the inferior vena cava to the heart, and then through the pulmonary circulation to the lungs, and this may cause pulmonary embolism. Then we measure the diameter of the legs. We point tibial tuberosity and the medial malleus, and we localize the midpoint between them, and at this point we measure the diameter of the leg, and same for the other legs, and we compare the difference in the measurement. If there is a difference of 3 cm or more, this is significant and may suggest DVT or inflammation. Then we mark the area of swelling with a pen. So if it's present, so that we can monitor a progressing cellulitis. Then we check the swollen lymph node if it's present along the affected leg and in the inguinal fold. That may highly suggest lymphoadenopathy. Then we examine the 4 abdominal masses, like a mass in right lower quadrant that would suggest a tumor that could be compressing the liver, that could be compressing the right iliac vein. This is all about physical examination. Now we will talk about DVT pathophysiology. Veins in the calf or thigh are the most commonly affected in the direction of venous flow towards the heart. But actually, DVT could be happen in the upper extremes, like subclavian vein and axillary vein. Rudolf Virchow is a German physician that described 3 factors that are critically important in the development of venous thrombosis. Let us remember she. S for stasis of venous circulation. H for hypercoagulability, and E for endothelial damage. These factors have come to be known as Virchow's triad. We will start by stasis of the venous circulation. Is a condition of slow blood flow in the veins, usually of the legs, as we said. Venous stasis is a risk factor for forming the blood clots in the veins, venous thrombus. Venous stasis can occur as a result of anything that slows the blood flow or obstructs the blood flow, and it's mainly caused by immobilization or immobilized patients, especially those hospitalized, like patients with significant heart failure, long travel, long bed rest, and patient with paralysis due to spinal cord injury. The second factor is hypercoagulability. Abnormalities of the blood coagulation that increases the risk of thrombosis. It results from a combination of increased circulating tissue activation factor and a decrease in circulating plasma antithrombin and fibrinolysin. Could be inherited or acquired. Inherited, the most common is the factor V Leiden mutation and protein C and S deficiency, antithrombin 3 deficiency, and prothrombin gene mutation. Acquired, like malignancy, especially in prostate, pelvic, abdominal, breast. Liver failure, sepsis, hormone replacement therapy like oral contraceptive, or a nephrotic syndrome where there is loss of protein in the urine. And the heart failure, as we said, because those people have already limited heart and lung function. And the age is also an important factor. Being over age of 60 increases the risk factor of hypercoagulability state, and being overweight or obese is also a risk factor. The third factor is the endothelial injury. The endothelial injury is the disruption of the endothelial cell barrier. This leads to expose of the subendothelium. Then the platelets adhere to subendothelial surface by means of von Willebrand factor and form aggregation. This is mainly caused by direct trauma, local irritation, especially in patient with cancer patient treating by chemotherapy, patient with past DVT and phlebitis, surgery, especially in orthopedic surgery, and in central venous catheters and cannula.
يعطيكم العافية. معكم زميلتكم جوانا خصوص، واليوم نكمل محاضرتنا عن DVT prophylaxis. نحكي عن signs and symptoms of DVT. In about half of all cases deep venous thrombosis بيصير بدون أي symptoms. ولما يكون في عندي symptoms مع deep venous thrombosis إيش بنشوف swelling in the affected leg including swelling in your ankle and foot. إيش سبب السويلينج هاد؟ السويلينج بيصير لأنه الثرومبس بمنع عندي drainage of the veins، فنتيجتها رح يصير في عندي blood pooling distal to the obstruction، وهذا رح يزيد عندي الهيدروستاتيك pressure، رح يعمل عندي pitting edema. تاني إشي رح نشوف pain in your leg. هذا البين بيكون موجود عندي بالأنكل بالفوت. والبين often starts in your calf and can feel like cramping أو Charlie horse اللي هو stiffness بالarm أو بالleg. بنشوف برضو warmth over the affected area، وبنشوف changes بالskin color such as turning pale, red or blue as a result of ischemia. لما نحكي عن warning signs and symptoms of PE، زي ما بنعرف pulmonary embolism هو من serious complication of DVT، وسبب pulmonary embolism هو لما يصير في عندي detachment of the thrombus وبنتقل على شكل embolus pulmonary circulation. clinical manifestation بنشوف dyspnea, pleuritic chest pain, cough, hemoptysis, acute core pulmonal هي بتصير نتيجة high blood pressure بالpulmonary arteries، بيصير في عندي زيادة بالworkload of the right ventricle، ومع الوقت هاي رح تعمل عندي failure ب right ventricle. physical exam بنشوف tachypnea, tachycardia, reals, cyanosis, pleural friction rub اللي هي بيكون سببها inflammation of the pleural layers of the lung rubbing together. هلا بنيجي نحكي عن الدي دايمر. الدي دايمر هو عبارة عن فبرين degradation product، تمام؟ هو عبارة عن بروتين بنلاقيه موجود بالبلود بعد ما يصير للبلود clot degradation by fibrinolysis. It is so named because it contains 2D fragments of the fibrin protein joined by a cross length. هلا الدي دايمر عنده high sensitivity up to 97% بس عنده poor specificity. إيش السبب؟ لأنه برضه بنشوف high D dimer بحالات تانية زي thrombosis, DOIC, recent surgery, trauma, malignancy زي breast bowel prostate بالpregnancy زي ما بنعرف it's associated with an increased risk of venous thromboembolism. liver diseases زي حالات السيروسيس، وبرضه بنشوف هاي دي دايمر ب renal impairment. هلا إذا بيجيني التست نيجاتيف للدي دايمر وحسب ويلز سكور كان عندي أقل من 2 بوينت، هون نعمل ruling out للدي بي تي. بس إذا بيجيني نيجاتيف دي دايمر والويلز سكور كانت عندي أكثر من 2، هون لازم نشوف تست تاني زي الالتراساوند، زي دوبلر التراساوند. إذا بيجي التست بوزيتيف والويلز سكور كانت أكتر من 2، برضو I need duplex ultrasonography. ليش؟ عشان أعمل الdiagnosis. هلا الدي دايمر should be disregarded بالهاي ريسك patient اللي هم الويلز سكور تاعهم بيكون أكتر من 6 point، أو I need to do other investigations. النورمال رينج إنه يكون الدي دايمر أقل من 52. coagulation profile Doppler ultrasound هو عبارة عن the first line imaging examination لل DVT، وهو عبارة عن non-invasive evaluation of blood flow through your arteries and vein، وعنده high sensitivity and specificity. إذا نعمل تست ثانيا زي الشاست اكس-راي للPE. بالPE بس 2% من البيشنتس اللي معهم PE بنقدر نشوف على الشاست اكس-راي ويستر مورك ساين وهامبتون هوم ساين، بس not very specific. وبقدر استخدم عندي شاست اكس-راي إذا إجاني patient ب symptoms of hemoptysis أو pleuritic chest pain، أقدر أعمل عندي أشيل احتمالات تانية زي pleural effusion أو pneumonia من خلال الإكس-راي. ال ECG بالPE نشوف pattern اللي هو S1 Q3 T3 اللي هو بيكون عبارة عن large S wave bleed 1 و large Q wave bleed 3 و inverted T wave bleed 3. ال arterial blood gases مهمة بالPE عشان it reveals hypoxia, hypocapnia and respiratory alkalosis.
Hello, my name's Emma Marianne, and I'm going to be talking about the management and prevention of DVT and pulmonary embolism. To diagnose DVT or pulmonary embolism, we must take a detailed history and physical exam and apply this information to a validated clinical prediction tool, such as Wells score, which determines the pre-test probability of pulmonary embolism based on clinical findings and medical history. Assessing the clinical probability is the first step of the diagnostic workup and determines what test to do next. For the treatment of DVT or PE, we either give anticoagulants to prevent further clot generation or thrombolysis if the thrombus is large enough, causing hemodynamic compromise. Prevention of DVT requires us to break Virchow's triad either by lifestyle modification, mechanical measures, or pharmacologically. Prevention of DVT in surgical patients is based on risk stratification. Risk factors are grouped according to severity and are added to produce an overall risk factor score, predicting which patients are at high risk for DVT, prioritizing the management of their care. DVT risk stratification. This is one way to classify DVT risk and how to manage each risk level. For the low risk group, thromboprophylaxis is not necessary and early ambulation is the way to go. For the moderate risk group, either mechanical measures can be taken or pharmacologically. And for the high risk group, both pharmacological measures and mechanical methods should be taken. This is a risk factor score to assess and categorize the level of risk. Group A, each item represents 1 risk score. Group 2, each item represents 2 risk scores. Group C, each item represents 3 risk scores. And Group D, each item represents 5 risk scores. And the total score categorizes the risk level. A score of 0 means no risk, and more than 5 is the highest risk. Now for lifestyle modification, avoid obesity and inactivity by avoiding excess calories, exercising and maintaining a healthy weight, avoid dehydration, avoid smoking and maintain normal blood pressure. Pharmacological prevention, we have unfractionated heparin, low molecular weight heparin, fondaparinux, and warfarin. Contraindications for pharmacological prevention is active GI bleed, recent hemorrhage, stroke or hemorrhage, hemorrhagic stroke or hemorrhage, previous hypersensitivity, a low platelet count, neurosurgical procedure within the last 30 days, and any particular patient risk-benefit considerations. Now, we're going to talk more about each drug. Unfractionated heparin is no longer preferred. It works by directly inhibiting the effect of activated factor 10. It also potentiates antithrombin 3. It is used to reduce the incidence of pulmonary embolism and recurrent thrombosis. It has an increased risk of heparin-induced thrombocytopenia and major bleeding. Prophylaxis of choice in pregnant ladies. It has an antidote, protamine sulfate. Low molecular weight heparin is pharmacodynamically more predictable. The low molecular weight fragments exert their anticoagulant effect by inhibiting the activity of activated factor 10. It has a longer half-life, and fondaparinux is a direct selective inhibitor of activated factor 10. It overcomes many of the disadvantages of the low molecular weight heparins. It requires a single daily dose subcutaneously, and there is no need to monitor the laboratory parameters. It is eliminated via the kidneys, and its half-life is considerably longer than the low molecular weight heparins. Warfarin, it's used for long-term prevention, and it has a delayed onset of action. It is a vitamin K antagonist, most commonly used oral anticoagulant. It inhibits the vitamin K-dependent clotting factors, which are clotting factor 2, 7, 9, and 10, as well as protein factor C and S. Therapy is initiated with a high loading dose, followed by a maintenance dose based on the INR. Due to the narrow therapeutic index, measurement of the INR is required throughout the duration of anticoagulation. The most common adverse effect is hemorrhage. Other adverse effects are warfarin, skin necrosis, and osteoporosis. It is contraindicated in pregnancy. Aspirin is an NSAID. It is an analgesic and it also works as an antiplatelet by inhibiting the production of thromboxane A2. The main adverse effects at antithrombotic doses is stomach upset, gastric and duodenal ulcer, hepatotoxicity, and GI bleed. It is contraindicated in patients with hemophilia. Aspirin must be avoided 10 days pre-op to allow platelets to regenerate. Warfarin should be stopped before surgery, replaced by heparin. The disadvantages of prolonged anticoagulation range from inconvenience of long-term INR monitoring to the more serious risk of major hemorrhage. In patients with an identifiable and reversible risk factor, anticoagulation may be safely discontinued following 3 months of therapy. Those with persistent prothrombotic risks or a history of previous emboli should be anticoagulated for life.
السلام عليكم. أنا أحمد عبد الله، طالب بسنة رابعة، واليوم بدنا نحكي عن ميكانيكال ميثودز. أولاً الميكانيكال ميثودز مقسمين إلى 3 أقسام اللي هم الانترميتنت نيوماتيك كومبريشنز، كومبريشن ستوكينج، وانفيريور فينا كاب فلتر. الهدف من هدول الميثودز إنهم يساعدونا بالكونديشن اللي هو DVT، ما عدا الانفيريور فينا كاب اللي هو بيساعدنا بالكومبليكيشنز تاعون ال DVT. ال DVT اللي هو Deep Vein Thrombosis هو كلوت بيصير بالفينز بالlower extremities. They affect people over age 65 عادة أو ناس immobilized. The DVT also is a very serious medical condition that can cause swelling, pain, tenderness in your leg. Sometimes the DVT clots can break free and stick in a vessel in the lung. And this blockage can be called pulmonary embolism. It is called pulmonary embolism. PE can cause shortness of breath, pain, and even sudden death. وعشان هيك في عنا هدول 3 methods mechanical methods اللي بيساعدونا بالDVTs. أولهم intermittent pneumatic compression. زي ما احنا شايفين بالصورة، هي عبارة عن إشي بنحط بالرجل بتلبسه. Okay. It is filled with air and causes and squeezes and then it deflates and relaxes. وهذا الإشي بضل ينعاد مرة، ثانية، 3، 4، بضل ينعاد كثير زي كأنهم contractions. هدول contractions they help move blood from veins towards the heart. زي ما هون مكتوب it also helps in breaking down some proteins in the blood that can cause clotting. استخداماته زي ما احنا حكينا اللي هم high risk patients for DVT. أولهم هم دائما ال immobilized patients زي المرضى اللي هلا عملوا surgeries. بعد السيرجري the patient is immobilized، وعشان صار هلا عنده surgery بيزيد كمان عنا الانفلاميشن which is a very high risk for DVT. injuries to the legs, strokes، وكمان إشي كثير مميز بالاي بي سي إنه it can be used to treat patients with lymphedema. Complications: discomfort, warmth and sweating beneath the venous leg sleeves. هذا الإشي we can prevent it by making sure that the cuff size is correct. حتى في بعض الأجهزة اللي بيكون فيهم cooling button. Peroneal nerve palsy and pressure necrosis of the thigh. compartment syndrome. skin breakdown هذا خصوصا بالelderly patients. وكمان مرضى عندهم medical conditions such as leg ulcers, burns و peripheral vascular diseases ما بنحط لهم IPCs. الموضوع اللي بعده اللي هو compression stockings. compression stockings هو خلينا نتخيل زي جرابات حرفيا. They are elastic garments worn around the leg compressing the limb. زي ما حكينا قبل شوي الكمبريشن هذا بقلل الدايمتر تاع الستاندد veins و it causes in venous blood flow return. Compression therapy helps decrease venous pressure, prevents venous stasis and relieves heavy and aching legs. indications DVT زي ما حكينا. edema ممكن تيجينا من ال DVT بس برضه في كمان other causes for edema زي ال pure circulation. varicose veins, phlebitis. هدول هم ال indications for compression stocking. لآخر موضوع عنا ال inferior vena cava filter. inferior vena cava filter من اسمه بنحط inferior vena cava اللي هو it is a large vein in the abdomen that returns blood from lower half of the body. blood clots in the veins of the legs and pelvis can occasionally travel to the lungs where they may cause PE زي ما حكينا blockage. الفلتر it reduces the risk of PE by trapping large clots. زي ما احنا هون شايفين in most patients with DVT prophylaxis against the potentially fatal passage of thrombosis from the lower extremities is accomplished with anticoagulation. بس الفلتر احنا بنحطه بالمرضى اللي الدراج ثيرابي ما عم بزبط معهم. An inferior vena cava filter is a mechanical barrier to the flow of an emboli larger than 4 mm. هاي هنا نقدر نشوف كيف شكل الفلتر. آخر إشي بدنا نحكي عنه هو إمتى نستعمل هذا الفلتر. لما يكون عنا acute proximal DVT or acute PE in patients with contraindication for anticoagulation. 2 recent thromboembolism. 3 active bleeding معناته patients with recent trauma injuries. بس يعطيكم العافية، شكرا جزيلا لكم.